Good morning, ladies and gentlemen. My name is Councillor John Robinson and I have the honour of chairing this morning's committee meeting. Welcome to the remote meeting of the Adults, Wellbeing and Health Overview Scrutiny Committee held today, the 5th of February, which is being recorded live to the Council's website and will indeed be available to be viewed for a minimum of 6 months. Please be aware that any footage from the meeting can be used in subsequent media broadcasts. I would like to give a warm welcome to members, officers and indeed any members of the public or media who are watching this live feed this morning. Before we commence with the formal business of the agenda, I would like to cover some of the housekeeping issues for us all to follow. So, can all participants mute their microphone? Wherever possible, blur your background. To speak, could you use the chat function on the right-hand side and type in RTS, request to speak. Remember, everyone in the meeting can see the messages that you place in the chat function. When invited to speak by myself, remember to unmute your microphone. Once invited to speak, please introduce yourself with your name and position, unless you've already. If you're having issues with connectivity, try switching off your video and use the telephone function. If connectivity issue overview and scrutiny management board, Councillor Crute will take over. Ladies and gentlemen, before starting the formal business of this morning, it is sad to report that over 100,000 members of the public and community of the United Kingdom have lost their lives with COVID, and indeed yesterday it rose to 110,000. With your agreement, we will hold a minute's silence in memory of the 110,000 of our community who have lost their lives, and equally important, the 110,000 families and friends who mourn them, and our prayers go with them. So if we could begin with a minute's silence, please. Thank you very much, ladies and gentlemen. Before beginning the formal agenda, I would like to welcome and introduce a number of key officers supporting today's meeting from Durham County Council and the NHS community of Durham CCG and County Durham Care Partnership. As always, can we welcome Councillor Mrs Hovels, who is the Cabinet Member for Health. Can we welcome Jane Robinson, the Corporate Director for Adult Health and Services, Amanda Healy, the Director of Public Health, Sarah Burns, hello Sarah, Head of Integrated Commissioning, County Durham Integrated Care Partnership, Michael Lang, Director of Integrated Community Services at the Integrated Care Partnership, Joseph Chandy, the Director of Primary Care at the NHS CCG, Christine Scollan, the Commissioning and Development Lead for the NHS Community in CCG, Jane Sunter, the Public Health Strategy Manager, Angela Harrington, the Strategy Team Leader for Durham County Council, Andrew Gilmore from our Finance Department, and last but not least, David Logan from Health Watch. To each and every one of you, thank you for joining us, and I hope you enjoyed this morning. And may we also visit and welcome to our first meeting of the committee our newly appointed non-voting co-optee, Gosha Chayasalaska. I hope you find the meeting interesting and enjoy participating in our discussions. So if we begin by item 1, apologies for absence. Ian?
We have no apologies for absence, Chair.
Thank you, Ian. Substitute members, I take it we have none?
We have no substitute members, Chair.
Thank you very much. Item 3, minutes of the meeting held on the 7th of November. May we agree them as a true record?
Agreed.
Good, thank you. Stephen, you would like to refer to item 6, Shotley Bridge Community, and give us a bit of an update? Thank you, Stephen.
Thank you, Chair. Yeah, members will recall at our last meeting we had an update from Rachel Rooney from the CCG in terms of what was being planned in respect of engagement in respect of Shotley Bridge Community Hospital. Subsequent to that meeting, there have been some media announcements around the funding envelope related to the Shotley Bridge Community Hospital. And we do have Sarah Burns in today's meeting, and I'd like to invite Sarah to just give members a brief update in terms of that funding envelope. Thank you, Chair.
Thank you. Good morning, Sarah. You're going to address the meeting, and welcome as always.
Thank you, Chair. So as you'll know, that this has been a long-running project that has had huge involvement from local members, the community, the CCG and our local NHS provider trusts. The original proposals around the replacement for Shotley Bridge were actually developed in 2016, which is now 5 years ago, which is some time. And at that point, we had £17.1 million in funding allocated to the project. Since 2016, the work on the hospital and the services that'll be based there has been refreshed. Quite rightly, we've undertaken a period of engagement with the public and with local clinicians. And the original model that was developed for Shotley Bridge didn't include inpatient beds. It now does include 16 inpatient beds, which obviously increases the cost of the project. There are a number of services that are planned to be in the facility, which include the beds, as I've mentioned, an urgent treatment centre, chemotherapy and medical investigations unit, therapy provision, so things like occupational therapy, physiotherapy, speech and language therapy, outpatient services, women and children's services, and a multi-use space for primary and community care services, and hopefully more non-medical services for people in that community to use, because as we all know, there are plenty of interventions that support people's health that aren't necessarily medical. We've also been, it's been confirmed from government that the Shotley Bridge Hospital is going to be part of the Health Infrastructure Plan programme, the HIP plan. And there's more information about that on the Department for Health and Social Care site. But there's a requirement as part of that programme to be carbon neutral, which increases the costs. It's an upfront investment which will benefit in future years the people that use the services and the providers that work there in terms of having a really energy efficient building. There are also things since 2016 such as the increased engineering costs, increased cost of land and general inflation, and all of those things have generally increased the cost of the project. However, what we are confident of is the funding is secured, that it is a good thing to be part of the HIP project because we know that funding is secured for that building and for the project to go ahead. We know from our engagement work that we have the right services for the community, although we will be testing that again at the end of February with a further period of engagement. What we don't expect in any way is that this will detract on any of the other services in County Durham. So this increased investment in Shotley Bridge isn't going to take away funding from other services that we have in other parts of the county, and want to give real assurance on that. The capital funding is part of for the build is part of a separate allocation for the NHS. Our core allocation for the delivery of services remains as it has been. And as colleagues like Michael are aware, and others, we are committed to the delivery of services from our other community hospital sites. We have seen how important they have been throughout the COVID outbreak to support continuity of care. We've done significant work to improve the services over the number of years, and that will continue. So wanted to give assurance for the committee on that. So hopefully that update clarifies some of the changes in funding that we have seen and some of the announcements in the press, Chair.
Thank you, Sarah. You've answered a lot of the questions I raised with Rachel yesterday. I've had representations from people who are not councillors, who are not members of the committee, from the concert area, the Shotley Bridge area, and there has been some concern about the future of potentially Chesley Street and other areas, and indeed Dryburn, for this extra 10 million. The concerns, Sarah, are this is a 50% increase in the funding for Shotley Bridge. Whilst not saying to say, you know, be ungrateful, any extra money is wonderful, and we say thank you very much and would take any money, anybody's money, for the development in the county. There is concern among members and the community members that how could you've got it so wrong with your costings originally? So the first question that I've been asked to ask by members is, who are not on the committee but from that area, is how could you have got it so wrong that you needed a 50% uplift? And you have partly answered that. Secondly, why was this not brought to scrutiny earlier? Why were we not advised of the HIT programme and of this potential issue before we saw it announced on the television that it was 30 million, not 20 million? So there has been some concern about how it happened. So whether you want to answer that, or at the moment I've got Councillor Temple, who is the local member anyhow, wishing to ask. So with the agreement, we'll park them questions and take Owen, and then you can answer all three if you don't mind. Good morning, Owen. Owen, over to you.
Good morning, John, and you won't be surprised to know that I am really pleased to hear about what is happening at Shotley Bridge, a hugely valued facility in our community, extremely important. Like yourself, I wouldn't want it to detract from any other area of the county. However, I think if we hadn't had the 16 beds, if we hadn't had a facility that was fit for the 21st century, for the rest of this century, it would have been a huge disappointment if a cheese pairing approach had meant that we didn't get that. So whilst I understand the questions that you're raising, from the point of view of my local community, I think there is unalloyed satisfaction at what we are likely to have now.
Well, that's great, Owen, and I think that's exactly what I expected from you. But the questions I was putting was as a global, on behalf of the rest of the county. Sarah?
Thanks, Chair, and thanks, Owen. So in terms of the costs, they were our best estimate at the time. A number of things have changed, the model has changed, and the number of services in there have changed, including in the infrastructure and building award comes with significant cost. And I think it's quite right, and that model has been influenced by engagement with the public. It demonstrates that engagement works, and when we were unsure as to whether beds needed to be part of the model, there was a resounding yes from the public and from clinicians that was necessary. So I think it's good to see that has influenced our decisions. So we've got different services in there. We have new engineering requirements. We have increased land costs in inflation and the requirements around that energy efficient model. All of those things combine to increase the cost of the programme. But I would assure again the committee that this capital funding stream for this building is completely separate from the NHS allocation to run services, and we wouldn't expect this to have any impact on any other health services across the county that are run.
Thank you. Sorry, interrupted.
No, that's fine, Chair. I was finished.
Just to say thank you very much, Sarah, and the fact that, like you say, you've got the 16 beds is consistent with all the same amount of beds in all the other community hospitals. And as Owen says, it's wonderful that Shotley Bridge, the old lady of the county, because I can remember working there, the old lady is going to be revitalised and we're going to see her. As always, thank you, Sarah. Gosha, would you like to come in?
Yes, thank you, Chair. I'm very new to this committee, so apologies if this is a stupid question. But I was just thinking whether we have procedures that would require to resubmit the budgets if they are different than 10, 15, 20% from the original one for this committee to have a look at, because obviously the whole project seems really good for the community. I think we all agree that this is an excellent development. It's just a matter of procedure of when the budget was approved, I guess, in the past, and when it was changed that it didn't come to this committee. So this is just a general question about the procedures. Thank you.
Thank you, Gusha. Sarah, do you want to answer that one? And then I know Stephen will come in.
Thank you, Chair. So the actual capital costs of the initiative are overseen by NHS England, NHS Improvement. So they will look at the project initiation document we've developed and our business case for services, and they will basically be assuring that they are in line with what we would expect for a development of this kind. In terms of the services that are delivered locally, I think that's a really important matter for this committee, for you to feel fully assured that we have engaged with the public, we have engaged with clinicians, and we have fully understood the services that are required for the community in Shotley Bridge. And I would hope with the ongoing work we've done with the committee and the work we've done with our officers and members working group that we have kept all fully involved and engaged at all points, so everybody understands the rationale for the inclusion of services that we are including in this project.
Thank you, Sarah. Stephen, there's nobody else registered, so we'll finish by coming back to you.
Thank you, Chair. It's just to assure members that in terms of the latest development with Shotley Bridge Hospital, we do know that there are future further engagement activity that's shortly due to commence, and also we do have an item coming to our next meeting in April on the findings, results and feedback from that engagement activity. So there will be an informal item on the next committee's agenda in respect of Shotley Bridge Hospital. Thank you, Chair.
Thank you as always, Stephen. Stephen, is there anything else you wish to raise on the minutes?
No, Chair.
Thank you. So we then now move on to item 4, declaration of interest. Nobody registered any? Item 5. Good morning, Rosemary. Rosemary, you did raise with me that you wish to raise a question in regards to patient reference group. So this is the point where if you would like to ask a question, I know Joe Chandy's on the call and I think Joe will answer hopefully the question. So good morning, Rosemary.
Good morning, John. What the group would like to raise is we've been told that there will be no patient reference groups in future due to staff having to work with frontline staff. In the past year, public involvement's been greatly reduced, went from 1 month meetings to 2 months. The last meeting was cancelled. The Mental Health Strategic Partnership Board hasn't met for 15 months. So we are very concerned as of what's happening now and what will be the plan for future public involvement. Thank you.
Thank you, Rosemary. I actually think I got that wrong. I've got a Sarah Burns' hand up, so I think Sarah's responding, not Joe. I do apologise, Sarah, I got that wrong.
Thank you, Chair. Joseph is joining the meeting. He's just currently doing some work in support of the vaccination programme, so he hasn't been able to join us as yet. At this point in time, many of the CCG staff have had to pause their regular work to support the vaccination programme and other essential work around COVID. And that's not something that we take lightly, but we have to put our resource in the areas of absolute need during what is an urgent and a crisis situation. So I hope you know, Rosemary, how much we value our engagement groups. It's purely a short-term issue of capacity. While staff are redeployed, we have to prioritise them for COVID response, and that we would expect that those groups will be up and running again in future. It's just an unfortunate consequence of the the current situation that we find ourselves in.
Do you want to come back, Rosemary?
Well, the main thing we're concerned about is we are aware of the demise of the CCGs in April next year. So what's planned for our future engagement?
Would you like me to answer that, Chair?
If you don't mind, Sarah.
Of course. And that's something we don't have all of the answers at the moment. We're still waiting for national guidance to come around ICS, and I know that there's a later item on the committee on that subject. It's extremely valuable to us engagement in Durham, and that's never going to change. We'll have strong place-based working, and engagement with patients and the public and stakeholders will always be part of those arrangements. What we just don't know at the moment is the form that will take, Rosemary. It will absolutely exist, but the how is to be determined and to be shaped by us.
Thank you, Sarah.
Thank you, Rosemary. Thank you, Sarah. So we now move on to item 6, integrated services, and you're going to do this one for us, Stephen, aren't you?
I am, Chair. Thank you. Good morning, members. Yeah, I'm Stephen Gwillan, Principal Scrutiny Officer, supporting this committee. And the report I'm presenting this morning touches on the item that Rosemary's just raised, actually, and it's indicating and including details of a consultation stroke engagement paper produced by NHS England and NHS Improvement regarding integrating care. It looks to put the integrated care system network, which was established across England, on a firmer legislative footing, and details are included within the report. So the report details and includes as an appendix the consultation paper that was published. It was published towards the end of November, and responses to the paper were required by the 8th of January. So we had a really short time frame within which to produce a response, and as such, in consultation with the chairman, a response was prepared and also is included within this report today for the committee's endorsement, and was submitted within the time frame for responses. Members will be aware that the committee has received a number of previous updates on the Better Health programme, which morphed into sustainability and transformation plans, and which now has morphed into the development of integrated care systems. We have an ICS for the North East and North Cumbria, and that was confirmed in June 2019. And that's a collaboration of commissioners, providers in the NHS, but also our partners and local authorities as well. It's really built on the NHS Forward Plan key element of integration of health and social care services. And as I've said, our current ICS contains the ICS and 4 integrated care partnerships, which are subdivisions of that ICS. The paper includes a map setting out that. You'll see that it's quite dated because it does reference 2 separate CCGs for County Durham. Obviously, they've merged into one CCG organisation. But I think in terms of the document itself, there are some key elements for that. And it's really seeking to develop stronger partnerships between the NHS, local government and others, including the voluntary and community sector. It really does promote provider organisations forming formal collaborative arrangements. Now, again, that's something that we've seen in action, and we've called on as a committee in terms of seeking to address what we know are significant staffing and organisational pressures within the NHS, specifically around certain disciplines. Strategic commissioning features strongly within the paper, and also the use of digital and data services to drive NHS and social care system improvement. And again, we've seen that in operation. It featured heavily in our recent GP services review, and obviously has formed quite an extensive role in delivering health and social care services during the current COVID pandemic. The document seeks to put ICSs on a firmer footing. It's looking to get legislation through government to take effect from April 2022. And in terms of the response developed on behalf of this committee, paragraph 15 highlights some of the key issues that we made to NHS England and NHS Improvement by way of representations, and they include first and foremost the disappointment that we weren't formally engaged in the consultation, and also the short timeframes within which to respond. It does reference the fact that we are cited on the development of the North East and North Cumbria integrated care system, and we have as a committee acknowledged the need and importance of greater integrated health and social care. But based on that partnership of equals between the NHS and local government and other key partners, governance arrangements are a key feature within any new integrated care system arrangement, and we reference the need for robust health scrutiny arrangements featuring in any governance arrangements established under any new legislation. The response actually welcomed devolution of some of the commissioning arrangements from NHS England and NHS Improvement for specialised services down to the integrated care system level. It gives us potentially more of a say in the services provided and the resources, where the resources for those specialised services will be allocated. But I think also it's important to note that we have a very strong and well-established place-based commissioning arrangement within County Durham, alongside a very well-established and robust system of integrated health and social care services within the county, and we wouldn't want any new arrangement to jeopardise or detract from those very strong arrangements that we've got in County Durham, hence the reference to an excellent track record in that respect. So in terms of the report, Chair, as I said, the formal response is included within the report. The recommendations at paragraph 18, before I go into that, we were planning to have Alan Foster, who's the ICS lead for North Cumbria and the North East, to attend the meeting. Unfortunately, he wasn't able to attend, but has given a commitment to attend a future meeting to provide an update on the outcome of the consultation. And with that in mind, Chair, the recommendations before committee this morning are to receive and note the contents of the report, to endorse the response to the paper that's been submitted on behalf of the committee, and finally to agree to the inclusion of a further item on the committee's work programme on further developments on the integrated care systems back to this meeting, Chair. With that, Chair, I'll take any questions on the paper. Sorry, Chair, you're on mute.
Apologies. We've got Councillor Bell. Good morning, Richard.
Morning, Chair. Richard Bell, Barnard Castle West, and actually a member along with the Chair of the Regional Scrutiny Committee that's been looking at this, though you wouldn't really know that, given that we weren't informed about it. So, given there's no one here from the ICS or from NHS England, perhaps there's not much point in me voicing my deep unhappiness about this consultation. We just heard in item 5 about patient reference groups being suspended because of lack of NHS capacity during the pandemic. Yet during the middle of a pandemic, on the 2nd of December, not only in the pandemic running up to Christmas, a 5-week consultation is launched, which I only found out about after the consultation had closed. So, Chair, my one sort of criticism really of your letter in response is that it's frankly in more diplomatic and mild language than I would have chosen to make about this this proposal, which frankly feels to me like a stitch up of the first order on behalf of the NHS. So that's end of complaint. But I think the manner in which this has been done, given that we have had regional scrutiny meetings dragging on years with very little progress, is absolutely appalling. And I would like that message conveyed to whoever it needs conveying to, please. I think the concern, though, if I can just move on to a question, is about the abolition of CCGs and what replaces them, and how that affects our relationship. We have built up over the years. We had 2 CCGs in Durham last year, or was it 19? I can't remember, moving into 1. But we've built up very good, close working relationships with those CCGs. We know what they do. We have good dialogue with them. We're able to hold them accountable. for the first time in many years, I actually felt that the NHS and the council through scrutiny were able to work very closely together, and we understood each other. And then just like that, somebody tears it all up. And yes, we're all for regional cooperation. We're all for economies of scale. We're all for specialising where it's necessary. But the deep concern has got to be that in abolishing CCGs, we lose a local focus, we lose that local engagement, and we lose that local influence. So, Stephen, question, I suppose, are there any crumbs of comfort in these proposals that you can give me on that score? Thanks, Chair.
No, thank you, Richard, because I fully support a lot most of what you've said. Stephen?
Chair, all I can do is concur with the sentiments expressed by Councillor Bell. Just in terms of the regional joint OSCs, there has been a similar response submitted as part of the consultation on behalf of both the ICP Joint Overview and Scrutiny Committee, which is managed and looked after and supported by Gateshead Borough Council. I know that committee has responded, as has the Southern formerly STP Joint OSC that Councillor Robinson chairs. A more generic response reflecting the views across all of the participants of that Joint Overview and Scrutiny Committee has also been forwarded as part of the consultation process. I think the issue is well made around the potential risks to our already established working relationships with our CCG here in County Durham, and that's reflected in the response that we've submitted. We make reference to the fact that previously, obviously, we had 2 CCGs for County Durham, and at one stage there was some discussions around the potential for those 2 organisations merging potentially with Tees Valley CCGs, and we made strong representations around the need to ensure that the CCG and commissioning arrangements needed to reflect the footprint of County Durham. And I think the response makes that similar plea as far as the future of CCGs are concerned. We do reference that it is a significant departure from the way that the ICP was being operated, sorry, the ICS and the ICP was being operated. We do have long-standing relationships with CCGs in other parts of our central ICP. In fact, we're already, or we were involved in a programme, Path to Excellence, which involved Sunderland and South Tyneside CCGs. So again, there is a history of relationships and collaboration across CCGs. But I do share Councillor Bell's concern, and it's reflected in our response. The positive relationships we've built up, the fact that we do have a CCG that is commissioning and delivering services in County Durham for County Durham, and I think it's the importance of ensuring that that Durham pound remains in Durham and services are continued to be delivered for the people of County Durham in an area that has historical health deprivation within it. So totally support Councillor Bell's views. I don't know whether there are any CCG colleagues that want to comment in respect of the development, but as I say, we do have a commitment from Alan Foster to come to a future meeting to discuss the actual feedback of the consultation.
Thank you.
Thanks, Chair.
Thank you. Before Joe comes in, I fully agree with both yourself, Stephen, and Richard. One of the advantages of this lockdown Zoom things is people are both, look, you can see them and you can record what they're saying. And certainly in the Zoom meetings, I've had assurances, and indeed the last Health and Wellbeing Board, from Neil O'Brien and Stuart Finlay, that the Durham pound will remain in Durham. So for one good thing of COVID is we have on visual record and on eternal record, we have had assurances that the Durham pound will remain with Durham. Because my concern, like yours, Richard, because we've had this conversation, is Durham gets split in 2. We've got the North ICP and the South ICP. And your area and my area, we don't know whether we're in with North or we're in with South. And other things are the future of our County Durham Foundation Trust, because it spans 2 as well. So this we were both on the same hymn sheet. I know we are, Richard, protecting Durham and the people of Durham and ensuring that the Durham gets the money. And as I say, Stuart Finlay and Neil O'Brien, I hope remain in the ICPs because they gave us the assurance that our money would be ours. Joe, you would like to come in? George Handry?
Yes, sorry, I'm here. So I totally understand the comments made by Councillor Bell, and later on I'm presenting an item on the primary care strategy, which again is the outgoing County Durham CCG's way of trying to demonstrate the continued investment that's needed for the Durham patients in primary care, and it's one of our methods of trying to sustain that funding beyond this current CCG. If Stuart, Neil and I remain somewhere in the structure after reorganisation, of course we'd have our corporate positions, but of course we all have either practiced or practice or professionally work in Durham and have an attachment to Durham, and that's partly the motivation why we took up these leadership posts in Durham, to improve the health and well-being of Durham patients. And so whilst we're in position, already you've had assurances from Dr. Finlay and Dr. O'Brien, we will do everything to ensure that we can put in place our ambitions for the Durham residents. Going forward, there's going to be a design piece of work, and I know Nicola Bailey is on that task group to look at what will be the new function, and then following that the form of the proposed new way of working from an ICS point of view. What happens at ICP level, because Stephen's mentioned the good working relationships already developed with what's currently the Sunderland and South Tyneside CCGs. So will it be something like an area team? Because as you're aware, our ICS footprint is the largest ICS footprint in the country. So, you know, the distance from local population is too remote to be meaningful in some respects of commissioning. And what would the place-based agenda and the place-based infrastructure look like around Durham and Sunderland and South Tyneside? Especially, we don't want to go backwards on that integration work that we've been doing over the last few years in our respective areas, bringing together health and care for the benefit of patients. So all of that's to be worked out, and with that would be financial flows. So the most important thing, going back to Councillor Bell's comments, is what delegated authority for money and decisions for our patients and our residents would we have? And that's all yet to be determined, but we will do our best along with our officer colleagues in the local authority to make sure we try and determine and shape as much of that as possible.
Thank you, Joseph. It just needs to remind them, but Joseph, that this whole organisation was supposed to bring GPs and primary care into making decisions. Well, it seems like that has been turned on its side. And welcome back to 1970, where we had the Regional Health Authority and 3 area health authorities for the North. And guess what? We have an integrated partnership for the North and 3 integrated little ones in the middle. It brings you back to the 70s. Jane, would you like to come in? Jane Robinson?
Good morning, Chair. Thank you. Just really echoing some of the things that Joseph just said there. And I think, you know, as chief officers, we're really determined that we want to kind of continue with our approach to integration to get the best possible outcomes for our local residents. And whilst there is some uncertainty, our focus is very much about how we continue to strengthen integration locally. So I just wanted to echo that point, really, Chair. Thank you.
Thank you, Jane, as always. We've got no other members wishing to speak, so can we agree the recommendations in paragraph 18? Thank you. So we now move on to the next one. Welcome. I'm not sure whether Amanda's doing it on her own or Jane's starting off, but it's the local outbreak management plan. Good morning, Amanda. Over to you, I think.
Good morning, Chair. Yes, I'll take members through this. I'm just going to share a presentation. Obviously, Jane is the chair of the group, so we'll refer to that as we go through. Can everyone see the slides? Great, that's lovely. Thanks.
Yes, thank
Chair.
you.
Okay, so I'm going to obviously give an update on our local health protection assurance board, which Jane Robinson, Corporate Director, chairs, and is a multi-agency partnership board having that oversight of our response to COVID. And I'm just going to run through a few things since obviously I last reported into the Scrutiny Committee. Obviously we continue to use our data and intelligence as best as possible, and obviously since the papers were submitted, this is Durham Insights, and we had 3 development sessions with elected members, which I think was on the recommendation of this committee, I think, which were really helpful, and had high attendance at those sessions, which was really positive. In terms of our current cases, so that was of the 7th of January, when we were busy developing the papers. Where we are currently at is 254.9 per 100,000, which sees us as at a rate slightly lower than the England average now, and a reduction of 40.2 over the last week. And I think, members, what we had seen, obviously, and I'll come on to it in terms of the lockdown situation, we had seen a rapid increase in our rates up to and just beyond the Christmas period. We had 2 days, the 29th and the 30th of December, where we actually had 500 cases per day in County Durham, and then again on the 4th of January, and that has been the highest. But since then, thankfully, our rates have started to decrease, and colleagues in the NHS and County Durham Foundation Trust are now also starting to see the hospital admissions starting to settle and reduce, including intensive care, which is also positive. This rapid increase is also against the backdrop of the new variant strain, which we saw emerging from Kent, and based on projections from our colleagues at Health Protection Team and Public Health England, we think that around about 70% of our cases locally are the new variant strain, not the South African strain. I will come back to that. So we are seeing that reduction now in our rates, which is positive. Obviously, what we saw in terms of the national lockdown, leading up to the national lockdown, we were in Tier 4 when it was introduced on the 19th of December. And then there was a huge amount of work done in the run-up to Christmas, particularly with our schools, because testing in schools was announced just before Christmas. There was some additional testing within care homes announced just before Christmas, and also there was guidance to our local university, which came out, I think, on New Year's Eve. So a lot of work did take place over the Christmas period, as well as obviously frontline services, and then a lot of that changed and had to be redirected once the national lockdown came into place on the 6th of January. And while it is slightly different to previous lockdowns, there have been, there's slightly more people at work. The message is still very much at this point in time: stay home, protect the NHS, and save lives. The next review is planned for the 15th of February, although we don't have any indication in reality at this point in terms of what the government's kind of plan or strategy is. Obviously, it was very much close schools as a last resort and potentially open up schools first. And obviously, we continue to work and support our schools with that through our education, but also through any cases that come out of schools. But we don't have a real indication of what will come through that review on the 15th of February. So under the Health Protection Board, we've seen a lot of work take place over the last few months. That has included linking into our work of the LA7, the 7 local authorities, as well as wider work across the North East. And some of that has been around the localising of test and trace, and I'll come on to that in terms of the local tracing partnership. There was the Beat COVID NE campaign, which was campaign based on insights from local residents across the LA7 area and very much taken a personal approach, as personal stories. I think we had Jazz, a bus driver from County Durham, on some of the adverts about really getting people to think about the implications of either bending or breaking the regulations, of which we know we still have got good compliance, but people were finding the social distancing the most difficult to adhere to. We also at the LA7 have their work around vulnerable populations, or clinically extremely vulnerable, North East work around care homes, obviously working very closely with the directors of adult services, and then a lot of work on testing, which I will come back to, and the rollout of the vaccination programme too. All multi-agency partners, including fire, police, Foundation Trust, Council, are all part of the Health Protection Insurance Board and report in on a weekly basis. There's a really good governance and reporting mechanism in place. I've got a separate slide on vaccination, so we'll come back to that. But very quickly, in terms of our spike detection tool, what we have in County Durham is a way of using our local intelligence on cases and on Durham Insight, where we see that variation in small areas. What we look at is if that increase in cases has been due to an outbreak that we can identify, such as in a workplace, or as a prison or a care home, and actually it can be explained. If the rate is still higher than what we would anticipate, what we now mobilise as a community response to that, based on those rates and engagement with a range of partners, including our compliance teams and linking with schools. And we did have this just before Christmas in Brasside and Newton Hall, and we run it on almost a daily basis, so we can rapidly respond to any increases in cases in particular geographical areas and try and communicate that with obviously local members so that they know it is taking place. Existing other settings are obviously still huge amounts of work, as I've already said, in terms of education and in our early years settings. With care homes, obviously with the rollout of the vaccination, double tracking that with continued work on infection prevention control and testing. Within community, there's been quite a lot of focus on workplaces, and particularly smaller supermarkets that came out through government, but we were already carrying out some of those places, particularly obviously as they remain open at this stage in the lockdown. And again, although the university has moved to almost all online teaching, there are a number of students back in the city who had either already returned or who had actually stayed during the Christmas period, and again we work closely with the university in terms of the student population and their staff. We have testing in terms of our local testing sites and our mobile testing units, and we're busy developing building on existing programmes with the university care homes and the lateral flow device testing, targeting that testing at particular communities, with our blue light services, with in businesses, with our frontline workforces who have to go out to work and can't work from home. And we anticipate that programme will be rolling out in the next couple of weeks during February. It's a huge task across the scale and size of County Durham, but will be ready, and it'll be very much seeking to find people with no symptoms who are to test positive. And ongoing work with our schools, as I've already said. And then in terms of outbreaks and funding, Jane is overseeing, Joe Robinson's overseeing the process for the allocation of the local outbreak control funding. So we will be able to share further detail on that at the next scrutiny meeting if this is on the agenda. And then in terms of our outbreaks, we continue to rapidly respond to outbreaks and work closely with colleagues at Public Health England to contain outbreaks. So we do have some underway at the moment in terms of prison, and children's residential home, and some workplace outbreaks, and there's an established process for that. Then one thing that has come into being since our last scrutiny has been the local tracing partnership. This is aligned to the community hub, and we have staff employed in the hub to contact positive cases where the national team haven't been able to elicit a response from them after 24 hours. And what we're finding, it's early days, we started this in January, staff have been trained, and what we are finding is that local contact and conversation is really getting people to answer the phone. We're understanding if they're able to self-isolate, what the challenges are, offer them the support from the hub, and we'll be able to bring a detailed report on numbers back through the Health Protection Assurance Board and to the committee next time. And then our COVID champions are absolutely up and running. We have over 70 of those COVID champions now, which is fantastic, and they respond when we've got a local response to the local spike detector tool. They're also actively engaging and giving us insight into the challenges and also the really positive stories about how people are coping during this lockdown. And then finally, Chair, in terms of the vaccination programme, which also feeds into the local Health Protection Assurance Board and to our local vaccination group, which is co-chaired from the CCG and with Public Health. And I feel a bit of a fraud, Chair, for presenting this, given their colleagues in the NHS who've done an absolutely remarkable job in terms of the progress that is being made in County Durham. Obviously, my role as Director of Public Health is to ensure uptake is as high as possible and that we address inequalities within that as well. But there's obviously the 3 vaccines that are approved and obviously more to be approved. The programme began across County Durham literally just before Christmas. You know, I know colleagues who had, some leave booked that certainly went out of the window when the vaccination programme was rolled out from the 14th of December. There were originally 3 strategic sites, and new sites are coming on stream all of the time, and as well as the mass vaccination site currently at the Centre for Life and obviously the Nightingale Hospital. And obviously at the moment, colleagues are working through those first 4 priority groups, which include down to the clinically extremely vulnerable. And we know that the data does remain a key issue in terms of being able to report fully on the data. However, it is getting better, and we do anticipate in the next couple of weeks to have a much more complete data set to be able to share more publicly. However, obviously, colleagues, where we do think we're at currently is out of our 27,500 80+ across County Durham, we've almost got 100% uptake of the vaccination. And then in terms of the priority groups, other priority groups, including our health and social care staff, we know that the hospital hub has vaccinated over 20,000 staff, both within County Durham Foundation Trust TUVE, and is also supporting the vaccination of frontline health and care workers. The vaccination centre was set up very rapidly at County Hall for frontline health and frontline social care workers, and has seen around about 500 vaccinations per day. So it is rolling out very rapidly, and the aim is to have the full vaccination of all 4 of the first priority groups from the Joint Committee for Vaccine and Immunisation by the 15th of February. The limiting factor is the supply. It is a push model rather than so the vaccine is pushed out to the NHS and to colleagues within the primary care networks, rather than being able to pull the vaccine as we are able to use it. And understandably, there are still some issues with the vaccination programme. We know obviously that the letter that came out to invite residents to the mass vaccination centre at Newcastle could have caused confusion for our local residents, thinking they had to attend there rather than having a choice. And that is being raised in relation to that. We also know that there is the need to focus on inequalities, and there is some dedicated work taking place to ensure that particular people who are in those priority groups who may not be registered with a GP can access vaccination as appropriate. That may be part of our homeless population, our Gypsy Roma traveller population, for example. And it's that health inequalities will come more to the fore as we go down the population groups within County Durham and see the numbers increase, and obviously issues such as access, transport and rurality come to the fore as the numbers do increase. I think, Chair, what we've got to remember as well is if we go through all 9 of those priority groups, that the mortality will reduce by 99%, which is absolutely what we want to see in County Durham. The local authority are working closely with NHS colleagues to support the vaccination programme, and know that will need to take place over the coming months, and that also includes support from other partners as well. Chair, I will stop there and hope that gives an overview of the work of the Health Protection Insurance Board in relation to COVID, and obviously the rollout of the vaccination programme.
Thank you, Amanda. Amanda, I've got a number of members wishing to speak, but as normal, I've got whoever's got the mic on, we get in the echo. Hopefully that's gone. No, but Amanda, is there any way we can stop the echo?
Steve, Chair, is it my echo? Is it echoing from?
Do you want to switch off, Amanda, and see if it's you? Has it gone? Yeah. Amanda, there is a number of members which speak, but as always, other members have approached me to ask the questions. So I always start off with them. The questions from other members are that yesterday morning, the Minister for Vaccinations was questioned on BBC News and said that the first 4 priority groups would be done by next week, and then the next 5 would be done by the end of March, before they start looking at teachers, police, fire, etc. So one of the questions that I've been asked by members is, how are we prepared in Durham to ensure that the remaining 5 priority groups are done by the end of March? Linked to that came a question of Newcastle, with half a population of us, has got 4 mass vaccination centres. Darlington, a fifth of our population, has a mass vaccination centre. Why have we not got a central, a massive vaccination centre on our population? And the third one that came in was, and the only way I describe it is haphazard way it's being rolled out, that 8-year-olds and 9-year-olds in some part of the county have had it, where others in other parts of the county were still waiting for it, when other parts of the county had 2 injections. Where we've got across the county, it seems to have been haphazardly done, which has upset a lot of population unnecessarily, because people are desperate to get the vaccine, and it seems to be, giving you more problems than it actually was solving. So do you want to answer them that came in for members, and then we'll move on to the 4 members who've requested to speak? Thank you, Amanda.
Thank you, Chair, and I'll answer, but I'll also bring in Michael, who's obviously key to coordinating the programme. And before I hand over to Michael, all I would want to say is, in terms of those priority groups, Chair, you mentioned the rollout to the end of March, but then teachers and fire, and obviously we know that that second phase would consider other groups. At present, it's very much based on that clinical need, which is very much predicated on age. But if I pass over to Michael to answer the other questions, if that's okay, Chair.
Thank you, Chair. My name's Michael Lane. I'm the Director of Integrated Care. If I can just start with the last question about the haphazard rollout, Chair, and that's partly because primary care started at different times. So wave 1 was asked to mobilise at the end of November and started in the week commencing the 14th of December, and then the second wave started on the 16th, and then the third wave was due to start on the 21st, but the government asked us to push that back to the beginning of January. And what that meant was that different people got the vaccine at different timescales. So, for example, that was all linked to the GP's ability to have premises where people could socially distance and get the staff in place to give the vaccine, and also, Chair, to be able to store the vaccine at that time in line with the clinical guidance, which was storing it at very low temperatures. So if I can just give an example, in the Dales in Barnard Castle, the Trust worked with the GPs and made the Richardson Hospital available, which is a big space, which has clinical facilities there and recovery facilities. So we could start that really early and make progress in the Dales. Somewhere else, for example, like Pelton and that part, the Chesty Street part of the county, needed to do more work to set up their vaccination centre and therefore started later. And you got that different time phasing for the residents of the county. And that explains what you've said is the haphazard but staged way that it happened. In terms of the mass vaccination centre, Chair, Chair, in terms of the mass vaccination centre, we did put forward 7 sites to the regional organisation as potential vaccination centres in Durham. I understand that they've now decided that they will have a vaccination centre. They were looking for premises that they could use for a year, so they were looking for a year's lease on a mass vaccination centre, and I think announcements are imminent on that, which will probably open on the 15th of February. And I'm unable to tell you the site at the moment, but I understand that the regional vaccination centre will be making those announcements. And I'm interested to see that the Minister has asked us to start on priority groups 5 and 6. We've been expecting that. We will start planning for that. Primary care networks are set up to carry out those mass vaccination programmes and are incredibly efficient at doing that. And if we have the mass vaccination centre, that will help. We also have the option of using the facility at County Hall, which, as Amanda says, was mobilised very quickly, Chair.
Thank you, Michael. I always feel sorry for you because ministers make these statements like you did on the telly yesterday and you have to implement it. But it was quite clear, because I went back after the member phoned me and watched it. It was quite clear that all 9 groups would be done by March. Then he would look at police and fire. So good luck. I really respect your work you're doing. Joseph, do you want to come in now, or do you want to wait until the other 4 members have spoken? Joseph, you've got your microphone off.
That's twice I've done that. I just wanted to add, Chair, to Michael's comments as I'm leading the general practice delivery of the vaccination campaign, that initially, as in the staged programme, as Michael described, the sites that got off the ground before Christmas were also giving second doses within 3 weeks of the first dose. It was only partway through the programme that the government nationally changed the guidance and extended it to a 12-week gap. It meant that the programmes that came later on were then able to quite quickly vaccinate more first dose patients, while the original programmes were doing their second doses. So you did have, for instance, in East Durham, especially in Peterlee, patients complaining about inequity because as the older cohort of over 80s were going through getting their second dose, the neighbouring PCN was, although starting late its campaign, going through its cohorts quicker because it was purely only doing first doses. So some of these anomalies that members have heard concerns about from patients around what appears to be haphazard is the country learning as the programme goes and directions changing as the programme's evolving, and that creates these anomalies which appear to patients why, how has my neighbour who's younger than me received my vaccine before I have? So some things have been out of our control due to this being an evolving and learning programme.
Thank you very much, Joseph. So we'll go at the 4 members and I'll come back to Michael because I'll get into bother. They've been waiting long. We've got Councillor Joplin, then Councillor Bell, then Councillor Brown, and then Councillor Reid. So Patricia, good morning.
Good morning. Patricia Joplin, Crook Division. First of all, can I just say that I have nothing but praise for the vaccine rollout. I've had calls, people are ringing me. I've had my vaccination. They are absolutely thrilled. They said that the local doctors are doing a wonderful job. So I just thought I'd pass that on because obviously you accept criticism. I think it's only right that you get the praise where it is. One of the questions I'd like to ask is about the lateral flow test and the publicity that's been behind the efficacy and how good it is. and how much we are going to, or how much we should rely on it. It is being quite widely used now. Can you tell me, have we done any work as an authority or through the health authority on whether it is as good or as bad as people are saying? Because there is a lot of negative press out there, which I think is not very conducive for getting people to use it.
Thank you, Patricia. Richard? Councillor Bell?
Thanks, Chair. My questions are related. I mean, firstly, it's overall, I think what we've heard from Amanda is really quite positive, that the rates are falling. If you look at the colours on the interactive map, they're all going in the right direction, and the vaccine rollout's going well. And I'm very pleased to hear the Richardson Hospital getting mentioned, because colleagues on committee have heard me for years banging on about it being an underutilised, wonderful facility. So there you go, where you've got these facilities, you can crack on and do it. So yeah, just on the lateral flow testing, I mean, my understanding is that its principal, benefit is to detect symptomless positive people with a high viral load who are symptomless. That's what it's really there for. That's what it's good for. And there was, I think, the big pilot done in Liverpool a few months ago, and I just wondered what the learnings were from that before we sort of roll it out. Because one of the issues I think we've got to recognise is it's not just test and trace. You've then got to get people to isolate. And I've heard figures of up to 40% of people who are contacts of people who have tested positive, not people who are positive, contacts of people who have tested positive, up to 40% of them do not isolate for various reasons. So putting all that into the mix, I guess I just wonder how effective the mass testing on a lateral flow basis is going to be from the Liverpool experience. Thanks.
Thank you, Richard. We'll do the other two, if that's all right, Amanda, then you don't have to be in and out. Councillor Brown, Liz. Good morning, Liz.
Good morning, Chair. Liz Brown, Neville's Cross. Not a question you'll be delighted to hear. Nothing but praise. All the feedback that I've heard, I've taken 2 members of my family to be vaccinated, and they've been absolutely superb. So a big shout out to everyone in the NHS who's dealing with the vaccine rollout. And I know it can't have been easy. Thank you, Chair.
No, thank you, Liz. And then, so you're going to go down to 2 questions at the moment, Anne. Amanda, so you're getting the 3rd one. Anne Reid.
Good morning. Thank you, Chair. My name's Councillor Reid and I'm from the Crook Division. First of all, echo what Councillor Joplin said and Councillor Brown. I've got nothing but praise for the NHS. I've had many people who've contacted me complimenting the staff at North House Surgery in Crook. They say that the vaccination programme has been very, very well organised. Everybody adheres to the safety measures. And they've got nothing but praise for the staff that are there. So I'd like you to pass that on, because I have had an awful lot of people come to me. There was only one, I suppose, negative aspect was that I learned that here in Crook there are people from the Dales who are having to travel down from the Dales, and I was a little bit concerned when one lady who was well in the 80s travelled down from Westgate, which is quite some miles away. She had to come down to the North House Surgery for a vaccination. So, I just wondered why that was the case. The other thing I was just going to ask for was really relates to the funding impact and the types of vaccinations that we have. So I would like to ask, what type of vaccinations have we got? I know we've got the Pfizer. Where are they manufactured? Do we manufacture them here in the UK, or are they imported? And do we know what any associated costs are and the full cost of the programme? Although I know that sometimes that's matterless when it comes to people's health. People's health comes far more, but I just thought it would be interesting to know. Thank you, Chair.
No, thank you, Anne. So, Amanda, you've got 3 questions, and I think you've got Michael in the background waiting to help you. So it'll be a double act. Amanda, so whichever one goes first.
Thank you, Chair. It'll be a team effort. Thank you. So if I answer Councillor Joplin's and Councillor Bell's question, because they both were similar in relation to the use of lateral flow devices, and I think you're both absolutely right to express some caution in relation to the use of lateral flow tests. We are using them as part of our overall programme of work. I think as Richard said, they're particularly effective at detecting people who do not have symptoms when they have a high viral load. So, and that is how we are aiming to use them locally. So certainly through the work within our care home settings, for example, they're picking up on asymptomatic staff and resident and staff. However, in our targeted community programme, and I use that word targeted really prominently because I think that is the learning from Liverpool, Richard, is that Liverpool was a mass testing programme which mobilised test sites across Liverpool, and however what was found from that programme was that actually the people who were coming forward were sometimes they worried well. It didn't really address inequalities, and there was quite a high percentage of false positives. So we have been learning from that. So the local programme that we will be implementing builds on some learning from the university, because they've been using the lateral flow devices for their students when the students returned home before Christmas. But we're very much going to be using the lateral flow to ensure we have a programme of tests, not just a one-off, at both community sites when they're open and for our frontline workforces who can't work from home, so that we'll be able to detect those people who don't have symptoms but who test positive. And then the second part of that is obviously ensuring that person can be supported to self-isolate, which again I think is really important. We raised issues nationally when there was no self-isolation payment, because we knew people, particularly from a business point of view, especially people working in some of our small businesses, we were finding from an outbreak situation that they weren't able to self-isolate. So we pushed for the self-isolation payment. And what we were doing is ensuring that if people test positive, both cases and contacts have access to information through the community hub that can communicate some of that support. So the lateral flow, we know that there are some reservations, and they're very much part of our overall programme, not the silver bullet. And we will continue to evaluate when we set out our programme. We'll be looking at our numbers, we'll be looking at the positives, we'll be looking at the number of false positives, and put that in context of our wider testing and our wider prevention programme as well. So I hope that answers the information on the testing. And yes, Chair, will hand over to Michael in relation to the vaccination. And all I have to say is lovely to hear obviously that positive feedback as well.
Thank you, Amanda.
Thank you, Chair. I have visited the North House surgery and I will pass on those comments, and they are doing a tremendous job. On the manufacture of the virus, of the vaccine, I think Pfizer is made in Belgium. The Oxford vaccine was initially being made in Germany and the Netherlands, but I understand is now UK made. And I think that the new vaccines that are currently going through the registration process, the Novavax, will be made in Stockton in Billingham. So even closer to home, and that's really good news, Chair. In terms of cost, there is a payment and cost framework for GP practices that is in place. So GPs are being given payment to deliver the vaccine. The trust is currently running 2 hospital hub sites, one in County Hall, which so far has vaccinated about 4,000 people. But as yet, we haven't really started talking about money. I think the priority for both the NHS and social care and the council has been to get people vaccinated, and we'll worry about the money later on, if I can put it that way. So the system effort is to concentrate on vaccination and making sure that we get those priority groups vaccinated by the 15th of February, and then we can move on to groups 5 and 6. So at some point we will do a reconciliation of the costs, and there are funding streams there from the government to do that, but the concentration at the moment is on vaccinating the population, Chair.
Thank you, Michael, and thank you for that reassurance. We've got two members wishing to speak, Councillor Crythorne and Councillor Henderson, and then over to you, back to you, Joseph. Pauline, good morning, back again.
Good morning, thank you. Councillor Pauline Crythorne, Bishop Midland and Colmforth Ward. I would like to echo the same as my other colleagues, the fantastic work the NHS staff are doing and the volunteers. I went for my vaccination at my local centre at Spennymoor and the service was excellent. Can I just ask a question, Amanda, regarding care homes? How far advanced are we on with the vaccination in our care homes? And have we any outbreaks of COVID in our care homes at the moment? Thank you.
Councillor Henderson, Ted.
Thank you, Chair. Mine is just to say that I had my injection last Saturday at the Richardson, and it was exceedingly well done, exceedingly well arranged. However, on Monday, both my wife and I received a letter from the NHS saying if we wanted to book a coronavirus vaccination, we could contact phone number 119 free of charge. Now, I know there's somebody that lives very close to me who rang up 119 just because he can't wait to have his jab done. And they said, oh yes, we can do that. We'll give you some places that you can go to. And they listed Morecambe, Leeds, Bradford and Newcastle. Now Morecambe's one a hell of a long way from Teesdale. And we're all advised that we shouldn't leave the county, you know, stay home. How come that when people phone up 119, they're being advised that they can go to Leeds, Bradford, to Morecambe, to Newcastle to get an injection? That concerns me a wee bit, because there are the people out there who will just take it up and travel there. Let's try and stop them going.
Thank you, Ted. I've got another member. Sorry, Ted, did I stop you? I do apologise. Was that it, Ted?
Yes.
Thank you. Sorry, Ted. I'm conscious that I've got another member before I bring any of your officers in. Councillor Savoury, Anita. Good morning, Anita.
Thank you, Chair. Good morning. I've had nothing but praise from the residents from Weardale who have had to travel to North House Surgery in Crook, and they've praised the way the operations has been run down there and everything. But could I ask a question, and can I ask why there hasn't been a site set up in Weardale for the vaccinations to be delivered? Like Councillor Reid said, from the top of the Dale down to Crook, from St John's Chapel, Isop Burn, those communities up there, it is a very long distance down to Crook, and we have a limited bus service for those who have to travel on the bus. So could you tell me why there wasn't a site in Weardale? Thank you.
Thank you. So this time, Amanda, you've got Joseph wanting to support you. So Joseph and then Amanda, because I know you've been waiting, Joseph.
Yes, I'll try and answer a few of those points. So the Weardale question from Councillor Savoury. NHS England specifically asked each primary care network area to nominate one site, because with the Pfizer vaccine, which is all we had at the time, they logistically couldn't deliver it from every practice, and the requirements around the mixing and constituting of the vaccine and the 15-minute wait meant to do it like an influenza programme from every surgery would make it very challenging for general practice when they have to run day-to-day general practice at the same time. So each primary care network was asked to use its local knowledge of residents and travel and capability of each of the practice sites, or sometimes a practice site wasn't the right place to deliver it from, and some PCNs have chosen community buildings like community centres, and make a decision for their population where that main site should be. And I think in your area that was North House. The CCG then took the unique decision, because I don't think that's been common across the country, to see if it could support transport. So although I can't answer the specific query on the lady that went from Westgate to North House, what I can say is that we were cognizant in many patches, not just the rural areas of County Durham, like for instance, the East Durham rural corridor patients having to travel all the way to Peterlee Health Centre, that for these vulnerable groups in the first 4 cohorts, it would be a challenge for them. And so we set aside money as a CCG to support transport, and every patient who has been in contact with their GP surgery who would find transport to the site a barrier had the option from their GP practice to be offered transport through our CCG transport booking service, which we set up temporarily just for this programme, and it's been supported by Cypher. So hopefully I've answered 2 questions there. With the introduction of the Oxford vaccine, which came much later in the programme, it does give the opportunity for primary care networks to rethink whether they can actually deliver the vaccine closer to home, closer to the patient from individual GP sites. It, as Amanda will support, it's still, there are some inflexibilities, unlike the flu vaccine, which just gets delivered to your surgery and put in the fridge, and then you wait for the patients to come in. Oxford vaccine, under the National Pharmacy Guidance, once it leaves the main vaccination site, which is North House in your area, it has to be in someone's arm at their local GP surgery within 24 hours. And the cold chain responsibilities and the moving responsibilities from a main GP vaccination site to an outreach GP surgeries is quite complex indeed. So some primary care networks have had the capability of taking that Oxford vaccine, if they've had a delivery, and moving it to local GP surgeries closer to patients. And some primary care networks have not, for various reasons. They've got to know that they've got the capability to do that. So I hope for Amanda I've ticked off a few of those questions that came. The 119, we can feed that back, but we have had patients who haven't yet been called up by their own GP vaccination programme because they're working through it systematically, who have had similar letters and been offered by 119, the Nightingale at Sunderland, and M&M Pharmacy in Bishop Auckland. So we don't know what algorithm 119 are using when they're offering outside the county, but I'll feed it back through Stuart, and Amanda will feed back as well, no doubt.
Thank you, Joseph. Amanda, you've got Michael who's going to come in after you. So we'll do you and then Michael, and we'll finish with Michael, because clearly we've got 3 other important items to go on to. Not saying this isn't important. Amanda?
Thank you, Chair. In terms of care homes, I'm actually going to bring Sarah in. Sarah's overseeing the work within our care homes. We are still managing a very small number of outbreaks, and I think it is really important to say that all of our existing measures that we encourage and support within all of our settings still need to be in place at this point in time until guidance changes. But I'll pass to Sarah to very briefly give an update on the care home vaccinations.
Thanks, Amanda. So as of Wednesday, all of our older people's care homes have been vaccinated, except those that are currently in outbreak. So we'll be making arrangements that once that outbreak has passed to go in and vaccinate residents. In terms of staff, as at Wednesday, we had vaccinated over 4,200 care home staff. That is just over 71%, and there's a concerted push to get the rest vaccinated. We have provided sessions for staff if they're concerned about getting the virus, information sharing sessions, and there's been a really collaborative approach. So pretty large numbers so far that have gone through the vaccination programme.
Thank you, Sarah. And finally, Michael.
Thank you, Chair. Can I just give Councillor Savoury some assurance about housebound patients? And I know members have been in touch saying that there are some people who are shielding who haven't been contacted by their GP to go in to surgeries. We are going out to vaccinate housebound patients, so there will be some people who are housebound in the Dales and elsewhere in the county who can't travel. So far, community nursing staff have vaccinated around about 2,500 housebound patients out of a list of 3,600. So we're working with the GP practices to make sure that we do take the vaccine out to people, and members may well have some contact from residents saying either I haven't been vaccinated, I'm not on the GP's list, and I am housebound. And we are working through that list, and we will by the 15th, if not slightly before, have vaccinated all housebound residents in the county, Chair.
Thank you, Michael. So, as you say, it's work in progress, but it's excellent work in progress, and with every step forward gives us all reassurance that we're on our way out of it. Thank you very much to everybody involved. So we now move on to item 7. We've just done item 8, which is the overview of suicide. Well, I really apologise, Amanda, because I'm back to you, aren't I? Amanda, I think you're going to introduce it, but I think Jane's going to do most of the presentation.
Yeah, thank you, Chair. I will be very brief given the time, and this is a really comprehensive report which gives an update on the scrutiny review, which focused on suicide. But what Jane has included within the report is an update on a lot of the wider prevention work that has taken place during the pandemic, which will obviously be a key part in keeping our suicide rates as low as possible. So, Chair, I'll hand over to Jane to go through the report. Thank you.
Thanks, Amanda. So I'm here basically within my capacity as the chair of the Suicide Prevention Alliance. And as Amanda said, the report itself actually gives an overview, first and foremost, about the 8 recommendations that were made as part of the Overview and Scrutiny Committee's review of suicide that began in 2016, actually, and we brought a report into the Scrutiny Committee last year as well. So just assurance for members of the committee, really, in terms of those 8 recommendations. All of those recommendations were actually integrated into our Suicide Prevention Alliance action plan and have now been completed or developed into further work. So I think in terms of that work, I think it's a real testament actually to real partnership working around some of these recommendations. Excuse me. Obviously, the impact of COVID on mental health has been significant over the time that we've been in the pandemic. And I think that the County Durham Mental Health Strategic Partnership remains our governance for the work of the Suicide Prevention Alliance, but actually also as well around that prevention work, as Amanda has highlighted, with wider partners. The Alliance has continued to meet throughout COVID and again had a really great attendance. So some of the work, just to highlight to the committee members around some of our successes really, and also work that is ongoing. First of all, in terms of our mental health at scale programme, we did have implemented a county-wide communications campaign that included World Mental Health Day and also our promoting our employee assistance programme for employees' workplaces, and then also other partners as well. I've included 2 appendices as well to this report that actually gives a list of services available, because I know you all get asked about, what services are available, how can I access them? So we've included those as part of that communications work that we did that can be used with local residents just to kind of signpost people into those services. The Suicide Prevention Alliance Action Plan reflects certainly new and emerging evidence that comes from Public Health England. Obviously, we've got the recommendations that were made through our health impact assessment on inequalities during COVID as well, and also ongoing project work that includes obviously work that now focuses on self-harm as well. So in terms of the kind of work that's been going on through the Suicide Prevention Alliance, we've looked at work that's happened around our real-time data surveillance. I think members will be aware of our progression really for the real-time data surveillance, which looks at the numbers of potential deaths that we have in an area. We also have a system as well that if we feel as if we have a number of criteria that suggests that we potentially have a number of deaths in one particular area over a period of time, then we actually have our multi-agency assurance review group that we can actually bring to actually see what's occurring in that area, look for community connections, and being able to mobilise wider partners within the community to actually engage to ensure that everybody's supported in that area. I think it's really important to say that during COVID, we really expected a potential spike in the number of potential deaths by suicide. That hasn't occurred. And I think that's something that we absolutely need to keep monitoring. And the real-time data surveillance system and our new dashboard is the tool that enables us to keep that close eye on any emerging trends. We also have done significant work around work that we've worked at a regional level around looking at interventions around social media. We've worked with Samaritans to look at that piece of work. We are also part of the regional work that's going on to look at emerging trends through suicide and debt. And also continue to develop and progress the work of the Time to Change Hub, where we have funded through the ICP, the Integrated Care Partnership funding, to look at small grant funding. We had 36 applications for that, 21 of which have been approved, and will be coming up to their 6-month mark at the end of March. We also have undertaken a big review of all of the contracts that are associated with our suicide prevention work as well. That includes that of If You Care Share, Relate, Welfare Rights and our cruise bereavement services, just to make sure that we have capacity within those services to oversee the mental health surge that we kind of have talked about within mental health forums. I've also added into the report an area around the crisis care concordat, certainly around the prevention agenda. Again, the work that's ongoing with the North East Ambulance Service and the fact that we now have a 24/7 helpline that has been instigated by CHU for those people who are in crisis. And that's really helped us be able to triage people to the most appropriate services. There's also funding that's been made available through the Mental Health and Learning Disability Partnership to Age UK, that's helping with home assessments, but also to reduce the levels of social isolation in our ageing population as well. The work of the resilient communities, there's not just only the group, kind of resilient communities themselves per se. As Amanda's mentioned, the work of the community hub has been significant, linking up with mental health needs of those people falling into the hub, significant volumes during times of demand, but also as well looking at how we progress that in terms of the connectivity with the COVID community champions as well, being able to report back if people are in distress and if people need further support. I've also included a demand, a section from paragraph 87 about the demand on Tees and Wear Valley services. We have absolutely continued to monitor the surge that we think might occur in those services. But again, our job is not to kind of prescribe those services within public health and within the Suicide Prevention Alliance partnership, but actually to, again, provide prevention work that will actually stop people escalating into the need for services. So again, we've had a very much a partnership approach to working across the system on mental health, and also the work with CHU has included that around what we term as moral injury for those frontline workers, and not just kind of the health and social care workers, but people who are bus drivers, people who are working in local businesses, people who have had to, be on the till in the shops, to ensure that they are provided with support as well during this this challenging time. So I hope this report enables committee members to look at how we've built on the original recommendations of the report and actually how we've taken that further and onwards and upwards. And I'd be happy to take any questions.
Thank you very much, Jane. Really appreciate that. We've got 3 people at the moment. Oh no, 4. So we'll take all 4. First of all, we've got Councillor Temple, followed by Councillor Stevenson, followed by Gosia, and then followed by Councillor Joplin. So can we begin with Owen?
Thank you, Chair, and can I apologise for not introducing myself last time? I was so carried away with my enthusiasm about Shotley Bridge Hospital. Councillor Owen Temple from Consett. I wanted to welcome this report as one of the members of the Scrutiny group that put that report together. There's obviously a vast amount going on that I just really wanted to say it's something we can never take our eye off in that committee. We look at the later report that we get on our performance in relation to localities. We know what's happening locally to us, and I happen to live, sadly, in one of the areas where suicide is particularly prevalent, and I'm incredibly worried about what COVID and the different behaviours that go on in our community may result in. So I welcome the report. It's very good, Jane, to hear of the many and varied things that are being done seeking to improve this, but this committee will never be able to take its eye off this until our rates are much lower than currently. Thank you, Chair.
Oh, thank you, Owen. Well said. We've got Councillor Stevenson, followed by Ms Chayeska, and then Councillor Joplin. Jeanette?
Okay, thank you very much, and thanks for the report, Jane. I mean, I've just been involved in the last couple of days with a search for someone who very sadly ended up having committed suicide, and lots of information and conversations going on online, and that was actually in Concert area in Black Hill, and you know, it was absolutely tragic. And what I do welcome in your report is all of those materials that you've given to us about where to send people, where to signpost people. Can I ask, can we share these?
Absolutely, they're a resource for the whole of the county.
Yeah.
So yes, if you could share them, that would be even better for us. Actually, get them out there.
I mean, I can't share them because I can't actually save them because they're actually part of this agenda package, which may be in a PDF format. I don't know. I just wondered whether there was any possibility of these being shared, you know, as individual, you know, JPEGs that we could actually share on our social media, because I think something like this is really, really helpful. So thank you very much.
Yep, not a problem at all, Councillor.
Thank you, Jane. So we now have Gorsha and then Councillor Henderson. Councillor Joplin.
Hello, it's Gorsha. I'm a co-opted member. I'm really, you know, pleased to read this report. It's a really important work. Very important for our community, and especially in these times. I was wondering, you mentioned prevention, and I think that's probably a key moving forward. And I know that some people in the area I live were waiting just before COVID about 3 to 6 months for to access to mental health therapies. And I was wondering if we've got any data of what's the average wait is at the minute for those therapies, and how we could perhaps approach this better access to those services. Thank you.
Before you answer that, Jane, should we get the other question from the councillor, and then you're free, because there's only 2 councillors. Oh, I think there might be somebody else. There is. Then yeah, Pauline, we've got Patricia Joplin.
Thank you, Chair. Patricia Joplin, Crook Division. I'm really pleased about all the work that's going on, and you're obviously stepping up an awful lot to try and capture the people that are suffering from mental illness. One of the things that I'm really worried about is the staff, the frontline staff. My granddaughter is a psychologist. She's a doctor. She comes home and tells me how absolutely the staff literally are running on adrenaline, and I am really concerned that when we start to slow down, and I can't see it for a while yet, but when that does happen, what sort of processes, because there's going to be not a small increase, there'll probably be a flood of people that are really, once they wind down and realise exactly what has happened to them and what they've seen, will really affect them. And she's overrun at the minute anyway. You know, she's doing extra work at night and this sort of thing. So there is going to be, I think, a backlog. And how do we capture that before that gets out of hand to help those people?
Thank you, Patricia. You've got one more, Jane, and then we are finished. But Stephen has agreed to sort out the JPEG issue that Councillor Stevenson raised. Pauline, do you want to ask your question? Then we'll go to Jane.
Yes, thank you, John. Thank you for the report. It's very informative. I'm reading on the information you've given us of different places where people can go to. But can I ask a question? In my area, we have a local charity, Comfort Partnership, who deal with a lot of people like this across the Four Together area. Do you feed in to small charities to see what's going on and how many people in that area they're actually dealing with? Because a lot of people go to the first local point, and it's sometimes where they live in the village. And I think maybe if you're feeding into them, you're getting a more local depth of what's happening in areas. Basically, that's all I wanted to ask.
Thank you, Pauline. So Jane, we've got yourself to answer the 3 questions, and then Michael Lang wants to come in after you.
Absolutely, thank you, and thank you for those questions. I think they all brought really good points, actually. I think there is a perception that certainly when we talk about the mental health therapies available, that there is a waiting list. I don't actually personally have the data about that, about how long they are at the moment, but I think it's really important to say that this is actually being considered at the moment under the kind of mental health community framework that is looking at basically reviewing kind of mental health services that are based within our local communities, and that mental health framework will be and it's got money attached to it as well, be something that currently is being led by TUV, but is in a partnership arrangement to look at how we can better integrate more mental health services within local communities so people aren't having to wait. And I think that kind of plays into as well the question about what's available within the community voluntary sector. Really significant partners within this as well, really. And I think certainly that we do provide support to local community voluntary sectors. We are networked as part of our mental health provider forum, so a lot of that conversation does actually occur, and I think it's it's a testament really that that we are kind of we are very joined up in regard to this. I think the work of the County Durham Community Hub is also significant. We've done a great piece of work where we have used the hub to actually be able to kind of respond to people phoning in distress and with multiple vulnerabilities. And again, I think COVID's kind of accelerated a lot of this process really, and that will certainly be something that we build on when we kind of look at the models for mental health resilience hubs coming out of the mental health community framework and other kind of more specialist need as well. So I think it's something that's ongoing, and again is, from my perspective, certainly within the mental health strategic partnership, but also within the Suicide Prevention Alliance, this is really part of that process really. Excuse me. And in terms of looking at the kind of numbers and the deaths that are unfortunate deaths that occur, we actually take our data from the coroner. So we've got a process that we are actually dealing directly with the coroner as soon as somebody has attended that death, spoken to the family. We then mobilise our post-vention support as well. So it's not only the family that are supported, but actually kind of the wider community as well. And then if we feel that we have themes and trends that actually mean that we have to reach out to the community to engage with them to also provide wider support, then that's actually when our multi-agency review work takes place, which is basically our kind of community response. So again, that is standardised, it's systematic, and it's based in evidence as well, which I think is really important.
Thank you, Jen. We've got Michael, and then we'll finish the item with Sarah. Michael.
Thank you, Chair. Just to reassure Councillor Jopling that certainly from the acute trust's point of view and for community services staff, right from the very top, from the chief executive and the board, they are very aware of the emotional intensity as well as the physical effort that staff have put in on the wards and in community settings, and they've increased the psychological support available and have really done a lot of work to go out to staff to give them support, but also to think about the long-term impact of COVID and to try and give staff support and to be able to feel that it's all right not to be all right. If you've had a really difficult shift in intensive care or on a COVID ward, it's all right not to be all right, and the organisation is there to support and help. And I think there's some really good work that's being done in the short term over phases 1 and 2 of COVID, and there are plans about what happens next after that in the future.
Thank you, Michael. And finally, Sarah.
Just a couple of points for information, Chair. So we've also worked with TUV to develop a psychological support service for social care providers. So in the event that there's been an outbreak in a care home, the team will go in and support either at an individual or a group level, and we've had some excellent feedback on that. In terms of the connections with the voluntary sector, the Mental Health Learning Disability Partnership has invested in some roles to actually connect mental health services, NHS mental health services, with the voluntary sector working in mental health, and I think we'll see some real benefits of that to come in the future.
Thank you, Sarah. So thank you very much, Jane, Amanda and everybody. And as Owen said earlier, it takes on the next stage what we did when we did our report on suicide. It does take it forward. So thank you very much, ladies and gentlemen. Can we now move to item 9, which is the one where Joseph's going to talk about primary care strategy, the development of a primary care strategy for County Durham. Welcome back, Joseph.
Sorry, was I on mute all that time? I can't hear anybody now either.
Yes.
Yes, you were, sir.
Right. I believe there's a presentation that'll be screen shared for me to talk through this item.
Yes, please, whenever you're ready.
Are you sharing it from your end, Stephen, or no?
I can share it, Joseph.
Oh, okay, right. I'll just make arrangements so nobody interrupts me while I'm in. Right. Has the technology worked? Fantastic.
Yeah.
So we just need to, Christine, switch to the PowerPoint. You might have to stop screen share and re-screen share. While Christine does that, I'll just start with some preamble. So
it's there, Joseph. It's there.
Oh, great. So as the Director of Primary Care, I feel privileged that this is the third primary care strategy in my tenure that I'll be bringing out for County Durham. It's not usual in a commissioning organisation that an organisation's around long enough, or the Director of Primary Care, to even bring out one primary care strategy, yet alone be on our third cycle. And it just shows that the commitment from the former two County Durham CCGs, now one CCG, when we were presented with a handover from the former PCT of primary care in 2013, primary care was in a very dire place. It was nationally and it was locally. We had a significant recruitment issue with GPs. I think there was a lot of challenges around investment, and the two prior primary care strategies focused purely on how we could improve recruitment, primarily GPs, but even more so widen the workforce. And secondly, it was about how we could increase the investment in our GP practices in Durham to be able to deliver more out of hospital. So this third strategy, linking back to the earlier comments made by Richard Bell and others, is unusual in that there's not many CCGs bringing out a strategy when they're concentrating on a transition from CCGs to something else, as we discussed earlier. We in County Durham feel that a strategy is essential because it sets out our roadmap of continuing what we've built currently and hoping to protect a legacy. Next slide, Christine. As has already been pointed out in this meeting, we actually work as a system, and I'm very proud of that. I think our work with the local authority and our partners in the voluntary sector and secondary care over the last few years has really crystallised, first of all through the work that was done with the Health and Wellbeing Board, and then the fact that it sponsored the Integrated Care Board and all the work that's happened since then. And so therefore it was important that our visions aligned. And as I said, it's to protect the legacy of what we've already built upon in the last few years around integration, sustainability of primary care, and care closer to home. Next slide, Christine. And we've been fortunate that since 2013 we've had enough run at this to actually make a difference for primary care in County Durham. And you know, just to highlight a few areas, extended access has been a big feature since 2013, where we've been open till 8 o'clock in the evenings and on the weekends, providing 7-day service, which has produced a significant amount of additional appointments. We've developed better access into general practice through the likes of care navigation. A huge piece of work that we did, which we commenced formally with Michael's predecessor, which was Leslie Jevons, was the development of TAPS. So directors that are in this meeting, such as Sarah Burns and I, work very closely with community, developed a whole new community contract, and developed the integration of our community services and district nursing services and other services to work very closely with our GP practices to create a multidisciplinary approach. Our attempts to increase the GP workforce has borne fruit, and we developed what was called a career start scheme, where we attracted newly qualified GPs to stay in Durham, because that used to be a significant problem. Over 40 GPs in the last few years have accessed that scheme, and we've also been doing that very successfully with practice nurses, and we hope to do that with clinical pharmacists as well. And the biggest strand of enabler to make that all happen was the investment additional into general practice, which we call our local incentive scheme. That local incentive scheme or local improvement scheme was about what services could be provided to our patients closer to home. You know, do they have to go into hospital to get their bloods done? Do they have to go into hospital for everything, or could we not have more specialist areas done at hospital? A lot of pathways have now transferred into general practice. If you're registered in a practice in another part of the country, it doesn't mean that you would receive that service from your GP practice, you would go to hospital. So the budget for those services closer to patients' homes from general practice is now reaching 7.6 million, which is a significant investment and probably one of the highest additional top-ups into general practice of any CCG in the country. And going back to the previous councillor's comments, this is one area that would cause me concern about how that could be protected into the future. Next slide, Christine. So we tried to make the strategy easy to read. So we've grouped it into what we think are the 4 strategic themes and what are the 4 priorities. And the strategic themes are about working together better. Really, everything we do should be built around that. And we've talked about the success that's given us already. And I think going into the future and about shaping the future landscape and what will happen around place-based arrangements will be a key theme in that strategic area. Sustaining primary care, right scale working. Primary care networks have shown GP practices that by working together, they don't just have to think about their own practice population, but what's right for the population of that community. And I think the COVID immunisation programme is a good example of primary care network delivery. We would never have had this before primary care networks. Next slide, Christine. And then we've got into 4 quite deliverables that we see are the key 4 important areas, which I think especially COVID has shown or exemplified the need for self-care. There are a lot of conditions that patients approach their GP practice for. We believe if we had the time to develop more self-care approaches, there is a lot the patient can do themselves. I think through COVID, a lot of patients are finding more confidence to be able to do that. We've also tied to that approaches around pharmacy, care navigation, social prescriber link workers that all promote patients being able to be supported to do their own self-care approaches. Digital was part of the long-term plan that over 10 years we'd move to a different world in primary care enabled by digital. COVID has probably accelerated that beyond what we could believe within 10 months rather than 10 years. And I know that I would hope that this committee would agree with me that access into general practice is far better than it has been. I know there has been complaints from across the country, not just in the county, that some patients, because of COVID screening and more remote GP practice consultations via telephone and video, have had some access difficulties, and I hope that's not the case because general practice is open for business. But digital has allowed patients to probably to have contact with a professional within the GP practice the same day, while previously the traditional appointments and face-to-face take 2 or 3 weeks to see a GP. Broadening the team is one of those major areas that would support getting quicker access into general practice. But of course, we've now promoted the adoption of roles like social prescriber link workers, general practice pharmacists, practice advanced nurse practitioners, physiotherapists working in general practice, physician assistants, paramedics. So that list is growing and growing, and what we're seeing is a transformation from the traditional GP practice model. And care closer to home we've probably talked about quite a lot now, and that it runs a thread through everything that we do. Next slide. And I think it's important to do the do than just talk, and so this sets out our roadmap of under those 4 priorities, how we would actually, from a nuts and bolts point of view, deliver on those areas. Next slide, please. And this deserves a slide all on its own, because County Durham's investment over the last 7 years has increased significantly to support the transformation of our general practice in County Durham. I'm very proud of the general practice that we've developed, and I think it's become quite a unique model and stands head and shoulders above general practice in the rest of the country. And our greatest concern as an outgoing CCG is that if this investment isn't protected, that goes into general practice to deliver our model, then this poses a challenge for the future. Therefore, we are setting out a new investment scheme for April 2021, which will be our last year as a CCG, and we have proposed that that be a 3-year scheme with a 3-year ring-fenced funding, and it's that we have to protect during transition. Next slide. And this slide shows the funding that goes into general practice now from County Durham, which is greatly significant to when we came into being in 2013, and we've shown that split against extended hours, GPIT, which has more prominence now, the local incentive scheme and other schemes. Next slide, please. I think with every strategy, you need to be able to measure whether it's working. So within this scheme, we have included trajectories on how we would continue to measure that for the remainder of this year and next year. And if members have any questions around that, Christine can give more detail on how we performance monitor. Next slide. This slide has been written bottom up. So I think one of the most timely things that actually happened was that this committee set up a task group, a task and finish group to review GP services in County Durham. And actually, in hindsight now, the timing couldn't have been any better in terms of contributing to what we would see as the priorities in primary care and how that would shape this strategy. Also, pre and post COVID, we had a high uptake from both the patients and public and GP practices on what they saw were the shortcomings still to be delivered on primary care. And that survey was so effective that it was rolled out across South Tyneside and Sunderland public to see what they found were the benefits and drawbacks of the general practice delivery model post-COVID. And that has all shaped this strategy. And it was important that we went out to GP practices and our patient groups, and we've done focus groups around getting their views too. Next slide, please. Oh, that might be it. Excellent. So, Chair, I hope that this strategy answers some of the questions that came up earlier in committee about moving into the new landscape and what the CCG's intentions are around protecting the Durham pound. I'm happy to take questions.
Thank you, Joseph, and thank you for that. And always remember, all questions and things go two ways. We would ask you what do you want us to do to protect the Durham pound, because it goes two ways, you and us. Joseph, one member left a question with me, so I'm reading the question that they asked is, what is the process for patients who can't get a face-to-face appointment with GPs? Are there any escalation processes in place? And we have Councillor Bell, so that's one question. And we've got Richard. Councillor Bell, you want to come in, Richard?
Thanks, Chair. Well, my question was essentially the same as yours. I mean, first of all, I just want to thank Joseph for obviously the reason that I am very, how can I put it, defensive of the CCGs is that I recognise that the excellent work that they've done, and particularly in primary care, that's just been outlined in the presentation here. So clearly we don't want to lose what we've already got. So my question, John, was very much similar to yours, really. What can we as the committee do? I'm kind of reluctant to concede that the, how can I put it, the battle to save the CCGs is over. But if it's been over, if it is, then what can we do to ensure that the legacy bodies as closely resemble the CCGs and all the plans that they've got for investment and protection of services going forward?
Yeah, thank you, Richard. You feel like you've been in a war, lost the battle, and didn't even know it took place.
Well, it feels like a Pearl Harbor moment to me, John, to be honest, but there you go.
Yeah. Councillor Craythorne, Pauline.
Thank you, John. I agree with everything what Councillor Bell said. I think we should look at ways where we can move forward to try and protect what is in County Durham now. But I would just like to ask, seems with COVID, doctors are under great pressures, patients can't access them as easily. Do you think we have done enough to use our pharmacies in place, promoting our pharmacies in place of doctors, to get patients to go there to take the pressures off doctors themselves at surgeries? Thank you.
Thank you, Pauline. So I think Pauline's question links into the one that somebody left about access, and then obviously what can we do to save you? So there's yourself, Joseph, and then we've got Michael.
Okay, so so with regard to face-to-face appointments, so every practice in County Durham has moved to what we call total triage, where every patient request for a consultation is triaged. It's usually a one-step process in that either the doctor or the nurse practitioner actually triages the patient's need and treats at the same time. This is something that wasn't done in the past commonly, but has proved from a clinical evidence point of view as effective as a face-to-face. But clinically, there are times where a GP needs to see the patient face-to-face, either because there are clinical clues, if you ask a clinician, that can only be determined or assessed by a face-to-face consultation, or the patient requires an examination. And it is the clinical judgment of that clinician who's triaging to decide whether or not the patient should come in face-to-face. Although COVID screening is important, and we don't want patients coming out of the home unnecessarily because of the risks of COVID, or the fact that they're coming into a healthcare setting and potentially mixing with other people, and that brings a COVID risk. The clinician's overriding factor is the need to see the patient on a face-to-face basis for the reasons that I said. That overrides the COVID imperative. So there should be no barriers from clinicians to see a patient face-to-face if they feel that a face-to-face appointment is clinically appropriate. There are demands placed by the COVID vaccination programme, because a lot of clinical staff from GP practices are manning that vaccination programme. So that is putting pressure on general practice, but shouldn't be a primary factor for determining at all whether a face-to-face appointment is needed over and above the first telephone triage appointment. If a patient finds they do need a face-to-face and they don't agree with the clinical decision to be treated remotely, either video or telephone consultation, they should take it up with the practice manager in the first instance and raise their concerns that they do feel they should be seen face-to-face, so that the practice manager can pick it up with the clinicians. I hope that answers that one. With regard to what can this committee do to support the Durham Pound lobbying through this transition process, I think you've got a number of officers in this attending committee today, like Michael Lang, Sarah Burns, Jane Robinson, between health and care, who will hopefully, and myself, Dr. Finlay and Dr. O'Brien, who will have a probably input into shaping the arrangements that are going to come forward, although we probably won't have the decision making. A lot of that will be done nationally or at ICS level. But when we bring forward and share these plans with you, how we believe place-based arrangements should work for our patients, including financial and decision making and budget setting, we would just ask for our committee to look through those plans with us and give it the appropriate scrutiny, because that objectivity is a gift really, and then stand by us in fighting our corner for what we believe is best for our patients. But I'll let the other officers on the attending committee today come in on that after I've finished. And the other thing about to add to access around pharmacy is that pre-COVID we were certainly working hand in hand with our pharmacies and promoting patients receiving care from pharmacies, and all our pharmacies without exception developed consulting rooms in their pharmacies. And I think the only thing that may have pushed that movement back from patients approaching pharmacies as opposed to their GP practice on a lot of minor ailments is COVID again, because the footfall into pharmacies will have reduced. But in addition to that, we do have, if GPs feel they're under pressure, as I said in the strategy, there are now a lot of staff that are attached to a collective of GP practices called a primary care network that we didn't have before. So a lot of the social determinants that impact on patients' health that necessarily a GP couldn't deal with their medical training, they now have access to social prescriber link workers. The practices themselves have their own practice-based pharmacists that can also support in medication reviews and minor ailments. A lot of presentations to general practice are musculoskeletal, and they usually went to the GP for a referral. Now they can be dealt with by a practice or PCN-based pharmacist. So there are many options now available, that are sometimes more clinically appropriate than just seeing a GP. So that should also be improving access significantly. Thank you, Chair.
Thank you. We've got Councillor Craythorne, Councillor Huntington, and then we'll go to Michael to finish this item off. Councillor Craythorne, Pauline?
Colin, sorry, John, can I just come back regarding the pharmacies? Yeah, and I know most pharmacies have private rooms where people can go for consultation, and COVID could be putting people off going there. But is it not possible where they could maybe have an appointment system at the pharmacies if it was advertised through the NHS, where people could phone up and arrange an appointment to see the pharmacist at a certain time, so they know when they go in, they won't be standing around, and it may help alleviate a lot of things.
Thank you, Pauline. I'm sure Michael will take that on when he speaks in a moment. Councillor Huntington, Eunice? Are you there, Eunice?
Yes, I am. I was just getting the hearing organised. Right. I just wanted to say I was in the early stages. It was really a brave new world, and we really tried to bring all the health services into the local communities. I remember going round factories and community centres and so on and organising basic health checks. And believe me, you would be shocked if you knew just how much and what came up. And these people hadn't sought help. And it's wonderful to see how far we have come on. Really enjoyed watching that and being part of this group, for example. And I would just share some of the concerns that have been expressed. And what, John, what you said, it's like we've had a take on, we didn't even notice that it was happening. It just sort of occurred. I would hate to think that we lost all the wonderful things that we fought so hard for, and now that the local people can enjoy. So I would just sort of agree with what people have said, and will be supporting that, which at whatever level that I'm working, I'll be supporting that.
Thank you, Eunice. Okay, Michael, do you want to finish the item?
Thank you, Chair. Just to pick up on Councillor Bell's comments, I think there are three things this committee can do to support the officers who are working to protect health funding and decision making in the county. I think the first thing is to give us your advice when we come back to you about integrating even more closely health and social care in the county. We are partway down the journey. There's still much more to do, and that includes acute services that are currently delivered in the hospital that could be delivered closer to home in the community. I think that the second thing is to exercise your scrutiny on any changes to local partnership arrangements that we will bring forward. So we really will strengthen those partnership arrangements so that it inspires confidence in the regional bodies to delegate finance and decision making to us. And I think the third thing is having a consistent message to the region and to the NHS nationally, so that there's a consistent message coming out from this committee and from the Health and Wellbeing Board and the Trust Executive Board and the CCG, that we have, as Joseph has said in his presentation, an absolutely tremendous track record in County Durham of integrated working. That needs to be preserved and built on, not dispensed with, and that we are more than capable of managing our own affairs and making decisions together and spending money together. And that's what we've done for the past 2, 3, 5 years. Joseph's shown that in his presentation, and that is the best way to serve the people of County Durham in the future. And if we consistently give that message, I think that is a tremendous advantage to us in making sure that this committee gets what it thinks is right for the people of the county. On Councillor Craythorne's point, I'll take that up with Joseph outside of the meeting, Chair, if that's acceptable.
Thank you, Michael. Stephen, do you want to come in and summarise where we go from here?
Thank you, Chair. Yeah, I think it's a positive that a lot of the comments and representations and concerns raised by members for this item echo those that were made in the earlier item around the emerging integrated care system. I think it's important from this committee that those issues that members have raised as part of consideration of the strategy are actually fed back to the CCG's Primary Care Commissioning Committee when they meet to formally agree the strategy, So on behalf of the committee chair, I think if members are agreeable to that, we will formally respond to the strategy and send a letter on behalf of the committee into that primary care commissioning committee, expressing the views of the committee and the support for the excellent integrated work that's being achieved in County Durham in partnership with the CCG, with providers, with the County Council and with the community and voluntary sector chair. Thank you
very much, Stephen. I think we fully support what you're saying. So thank you very much, Joseph, Michael. So we now move on to item 10. Angela, thank you for bearing with us and waiting such a long time. Angela, you've got to do the Q2 performance management report.
Yeah, thank you, Chair. So I'm Angela Harrington. I'm a strategy team leader in resources. So this report it covers the Q2 period, which is for July and September 2020. So during that summer period, the Council continued to work hard, as you've already heard, with partners and our communities to respond to the COVID-19 pandemic, and we also played a key role in the regional response. By the end of September, so that's sort of this period, our OPAL tracker, so that's the Operational Pressures Escalation Levels, that's why we have it as an acronym. So that's our criteria that we use to monitor and manage the crisis situations in the care provider sector. So by the end of September, that showed an improved position from Q1, in that most of our older people care homes had no significant issues with either COVID-19 infection, PPE or staffing levels. The second wave, which started to kick in then, led to a small number of providers starting to experience pressures during September, and we continued to provide coordinated and targeted support to all care providers operating in the county. So Sarah's already mentioned earlier in the meeting the sort of the care home mutual aid meeting and that integration across health and social care, which continues. And of course, we're still providing that support across those integrated systems. And we also work closely with the local care quality commission leads as well. So in Q2, the number of referrals for adult social care returned to their pre-pandemic levels. So after dropping by 18.5% during Q1, they picked up again, and there was an improvement in the timeliness of assessments. So 92.4% of annual assessments or reviews were completed in Q2, compared to 87.9% at the same point in the previous year. I think we're all aware that sort of permanent admissions to residential and nursing care continue to be lower than in previous years. Admission rates for the period April to September 2020, so Q1 and Q2, are less than half that for the same period in the year before. However, the number of people in receipt of home care has increased over the same period, so the reduction in residential care admissions is similar to the increase in those receiving dom care, domiciliary care. Focused activity across mental and physical well-being, smoking quitters, especially pregnant women and new mums, and breastfeeding continue to make a difference to the lives of our residents. And the data for this quarter in this report shows slight improvements. For example, compared to the same period in the previous year, we had a lower proportion of mothers smoking at time of delivery and a greater percentage breastfeeding. Over the summer period, we also promoted the benefits of physical activity and healthy eating to families. A booklet was distributed online through the AAP coordinators and the holiday activities with food groups, but we also provided paper copies to families who were stuck at home because of the pandemic and didn't have access to the internet. The long-term impact of the pandemic on mental well-being is widely reported, and we've already discussed that earlier in this meeting. We know that more people across all age groups are seeking support through primary and secondary mental health services, and also that young people with a history of mental health issues have reported increased anxiety, isolation, and a loss of coping mechanisms and motivation. You've already had an update from Amanda and Jane earlier in the meeting about mental health, wellbeing and suicide, and as their report mentions, we also cover in the performance report that collaborative work has continued between the Suicide Prevention Alliance and partners, including the voluntary and community sector, with some positive results. And since the start of lockdown in March 2020, we've not had to have any multi-agency assurance reviews, and through our regional real-time data surveillance system, the number of suspected suicides has remained comparable to previous years. So we had 59 in 2020, 46 in 2019 and 66 in 2018. And of course, across the workforce, we've already mentioned that today, you know, to support the mental and physical well-being, certainly of council staff, we've had sort of top-down approach to support the workforce. We promoted and took part in activities for National Fitness Day in September and World Mental Health Day in October. And of course, we continue to support all staff, frontline and back office, as they cope with the various challenges of the pandemic and trying to manage a healthy work-life balance. So thank you, Chair, and I'm happy to take any questions on the report.
No, thank you, Angela, and thank you for waiting so long. At the moment, we've got nobody, so can I say thank you very much, Angela? People have read the report, because I know they have, because I've spoken to people beforehand, and often when you get an in-depth report, it stops you asking questions. Thank you very much, Angela.
Okay.
So we now move on to item 11, which is going to be presented by Andrew. Another one, I have to apologise, because Andrew, you're always at the back, but you always start with us. Can we welcome Andrew Gilmore? And Andrew, you're going to do our revenue and capital outturn.
Thank you, Chair. I'm just proposing, on the basis of time, that I'll whiz through a monologue, which will only take 2 minutes, if that's okay, which complements the PowerPoint. Hopefully that suffices today. Right. Clearly, the first half of 2021 has been challenging for many reasons, and the forecast presented today includes a number of assumptions which could change in time depending upon circumstances. Durham County Council received a headline grant of over £40 million in respect of COVID-19 cost pressures, although there are various other COVID-related funding streams which has also been made available to the Council. And of this, approximately 22 million of the headline grant has been allocated to support pressures within the AHS budget. So clearly, overall expenditure is significantly higher than original budget. However, because of the way we account for it, within the overall position, there is a cash limit under budget for AHF of over £3 million after utilising the additional government funds. Within the £22 million of COVID-related cost pressures, 19 million is to provide support to adult social care providers. Other COVID-related pressures include £2 million or so for PPE and some additional staffing and double running costs. The position also includes over £5 million under budget, directly attributable to the COVID pandemic. So things such as 400,000 in respect of reduced transport costs, a reduction of over £4 million related to activity in care homes, and a contribution from Ccg towards adult social care provider support. In terms of the reported AHS cash limit position, £3.2 million under budget equates to approximately 2.5% of the overall net budget, and from a finance perspective indicates an ongoing well-managed approach to budgets across the service. And I don't want to go too much into the detail around different services, but I'm happy to take questions on that, and just a little bit about the 5 main areas of support which I've identified in terms of providers. So we've provided advance payments equal to one normal 4-week payment period that were paid to providers in early April. These payments are fully recoverable by DCC in due course. In recognition of a significant reduction in activity of some care homes, DCC, with support from the local CCG, agreed to make sustainability payments to support care home occupancy. Stability payments are being made to some providers, mainly in respect of daycare, to recognise the short-term reduction in activity as a result of COVID, for example, shielding. In addition to the above measures, in recognition of national concerns on exceptional cost pressures due to COVID-19, DCC, with support from County Durham CCG, made additional uplift payments to providers each 4-week period from the 19th of March. The government made available significant infection control funds, and these monies have been passported in full to providers. Separately, there are no specific AHS capital schemes as at Q2 this year. And just thanks for your time. Happy to take any questions. Hopefully that was relatively succinct.
That was perfect, Andrew. As always, Andrew, you've got Councillor Mr. Bell would like to ask a question.
Thank you.
Richard.
Thanks, Chair. Just on the 10% additional uplift fee related to the occupancy levels of care homes. I know that that's finished now, hasn't it, Andrew? Do we have any data on what the occupancy level of care homes is like, and is there any issues on the viability of care homes going forward, and when we will get back to normal, whatever normal is? Have you got any thoughts on that? Thanks.
I think knowing the future is quite difficult on that one, but we certainly at this moment in time seeing less than usual activity in homes. In terms of the actual money you're talking about, there's two elements to it. The sustainability payments are because of reduced occupancy, and they are continuing for a number of homes. There was an additional uplift which was linked to 10% of fees, which that stopped at 31st of October, but we're considering additional support in the short term. Does that answer the various parts of the question?
It does, yeah. I didn't realise there were two elements. So there's the general 10% uplift, but you're continuing the sustainability payments where they've got issues on occupancy levels.
If occupancy is less than 10%, more than 10% less than usual, yeah, we're paying sustainability payments to homes. Yeah.
Right, thanks.
Yeah.
Well, Andrew, no more questions, so thank you very much, Andrew. We've got Michael and Barbara left from NHS, and we've got Jane from social care. As we close the meeting, I think I'll speak on behalf of all 126 county councillors that we would like to pass on our most sincere thanks to all the staff that work with you, Michael, Barbara, Jane, for all the work you're doing, and for the fact that through you we see the light at the end of the tunnel, and we really do appreciate everything you're doing for us. And I know every single county councillor is right behind you with whatever support you want us to give you. So, ladies and gentlemen, thank you very much for this morning. There you go. You even got a clap, Michael. Can I wish you all have a lovely weekend and see you in March. Thank you very much, ladies and gentlemen. Good afternoon.
Bye.
Goodbye, Chair.